At the outset, thank you so much, sir, for inviting me and having me over this IC. And it's truly a pleasure being there with all of you. So today my talk in this is really going to be highlighting initially about biomechanics, and then talking to you all about how it is making a difference in our day-to-day refractive practice. I'll try to bring in some literature, some basic points, as well as some practical points towards the end. So the need is, we definitely need better screening criteria. Dr. Jaya presented a wonderful talk on Pentacam, which is still remains the gold standard. Most of us follow that as the basic for screening any case. But can we go beyond it? Now, as we are moving more towards from tomography, as we are reaching the apex of tomography, we are trying to see if there is a greater emphasis on biomechanics, especially with the advent of SMILE, combined procedures with cross-linking, which are saying that biomechanically it could be superior. Can we actually test these procedures using biomechanics? While all the Scheimpflug devices that we have, the Pentacam, Galilei, are all excellent, they are very, very good in differentiating normal from keratoconic eyes. But we are not really looking at differentiating normal from keratoconic eyes. We are really looking at differentiating normal from form first keratoconus, which continues to remain a challenge, because the definition of form first keratoconus itself is a challenge, and I'll allude to that briefly in the next part of the presentation. So corneal biomechanics, essentially, it is just based on the deformation of the cornea to an air puff. And initially it was Ora. It is now we are using the Corvus. And this dynamic from how a cornea changes when this is a normal cornea based on the air puff, you can see it has an initial flattening and then a slight concavity and then returns back to normal. This dynamic response is what we measure and through which various indices are brought in. This is a keratoconic eye. You can see that the deformation is much more prolonged, and the amplitude itself is much greater. So essentially what we are seeing is, from a normal state, from the initial convex state, it retains a flat stage, which is called applanation 1. And based on that, we measure that applanation length. And then it goes on to a concavity. And this concavity is from the highest concavity to the normal state is what we measure as the deflection amplitude, the amount it has deflected. The curvature along of the deflection itself is called the bend radius, and the inverse of that is called the inverse corneal radius. I'm not going to bore you all with too many technical details, but suffice to say that based on this is what the entire Corvus is based on, and all the indices are based on this basic measurement. It also gives us IOP and pachymetry, and also a biomechanically adjusted IOP, which is also very, very useful. This is the basic screen of the dynamic corneal response. Like I said, it gives you the deformation amplitude, and then it also gives you an important ratio. That is the center, the area which gets deformed maximum, and the ratio to the 2 millimeter from the center, which is the DA ratio, which is also very, very important. So a greater deformation amplitude, a shorter applanation length, and a higher DA ratio, and a higher inverse corneal radius are all indicative of a softer or weaker cornea. The newer report which has come into Corvus is the Vinsigera screening report. And this Vinsigera screening report has 4 major criteria and then gives a single index called the Corvus Biomechanical Index. This Corvus Biomechanical Index has the DA ratio at 1 and 2 millimeter. It has something called the integrated radius. Then you have the ARTH, the Ambrosio's relational thickness to the horizontal profile, and an SPA1, a nominal stiffness parameter, which has been brought about by Dr. Cynthia Roberts. And each of these parameters have a particular weightage to give you what we call the CBI, Corvus Biomechanical Index. I can go into each of these parameters, but since many of us are not using Corvus, it may not be very useful. But suffice to say that the CBI is a very sensitive and important index to be kept in mind. It also gives you a stress strain index. So the stress strain index is actually a curve of a stress to strain. Normally, we were only measuring it in vitro, but now there is an in vivo measurement which is available. So essentially, whenever it is moving to the right, a value of greater than 1, it's a stronger cornea. A value lesser than 1 is a softer cornea. The normal value is close to 1. So this is just an example of a patient with an absolutely normal pentacam, and normal overall D was in the white, and everything is in the bad display is normal. But when you look at the CBI, it is quite high. It's very, very abnormal. So when you look at the other eye, the fellow eye of this patient, this was significant keratoconus. And this is yet another example of a patient where the one eye was absolutely normal, other eye had keratoconus, but CBI was abnormal in both the eyes. So the biomechanics in the seemingly normal pentacam is also abnormal. And this brought about the first paper by Vinsigera, where they looked at 12 eyes of what was perceived as unilateral KC, that is KC in one eye, but the other eye is tomographically normal. And this is actually our definition of form first keratoconus. That is, a patient does not have KC tomographically, or doesn't have any specific signs in that eye. So it's only abnormal biomechanics. Now, with the combination of Corbis, we also are able to combine it with the pentacam, and we have another index called the TBI, the tomographic biomechanical index. The tomographic biomechanical index has been shown to be even more sensitive than the CBI. So you have the CBI, the bad D, and the TBI. And if you look at the ROC curves, a cutoff of 0.79 of the TBI has been found to be 100% sensitive and 100% specific in picking up cases of form first keratoconus. So this was a very important landmark study where they compared the bad D performance versus CBI versus TBI. Here, getting 480 normals, 204 keratoconus is fine, but it is these 94 eyes which really make a difference. These 94 eyes are patients where they have ectasia in one eye, but the fellow eye is absolutely normal. So let us look at the performance of each of these indices in differentiating the two. So here mainly you want to differentiate between the normal and the seemingly normal tomographic eye of the very asymmetric ectasia fellow eye. Bad D, if you see, it is almost similar to that of a normal. It is not able to differentiate. If you look at the CBI, it is easily able to differentiate KC and very asymmetric ectasia. But when you look at the fellow eye of the very asymmetric ectasia, it is able to differentiate, but the spread of data is very, very wide. But here, TBI, it is an excellent performance where it is significantly able to differentiate between normal and a very asymmetric ectasia. And the median value is actually close to that of a KCI. So that is how significant TBI has been in this study. But just to provide a contrarian view before I close with this talk, this is an eye, and this is not just the only example. I have several examples of these patients. One eye, absolutely normal, very thick corneas, completely normal bad D. CBI is normal, is at 0, TBI is at 0.07, everything is completely normal, but the other eye has frank and probably advanced keratoconus. So we are still a way off as far as differentiating this is concerned, and there are still some cases which the TBI continues to miss. How about decision making? Has it really changed the way I choose my refractive procedure? This was a patient which I saw today. I just included these slides while Dr. Jaya was talking, and this is a patient with a significant IS asymmetry, 1.8 diopter. Overall D is normal. We repeated the scan multiple times to ensure that the scans were taken properly to rule out a decentered apex syndrome. This is again the other eye which also had a significant IS asymmetry, and the overall D was normal. I tried to look at the CBI and TBI. The CBI is also normal. TBI is also normal. Now this patient has a -8 diopter sphere and -1 diopter cylinder. So would anyone, considering the fact, despite seeing the significant IS asymmetry, be brave enough to do a SMILE or LASIK or a surface ablation procedure? I went on to advise this patient a phakic IOL. Has this biomechanics made a difference in my clinical practice in the way I select my procedure or choose my procedures? Honestly, as of today, I don't think it has made a significant difference. Yes, it is a step in the right direction. Yes, it is a step in the direction where we are wanting to head towards, in the sense we are wanting to have 0 cases of iatrogenic ectasia and rule out even the smallest cases of FFKC. But in the normal cases, where I have a doubt in the pentacam, the CBI or TBI are corroborative evidence, but not making a huge difference altogether. Brilliant microscopy has been around for the last 10-15 years. We've been hearing about it over so many lectures. I had the privilege of seeing this firsthand and seeing it being used firsthand in Professor Seiler's hospital. Brilliant microscopy is really useful, that it measures the individual layers, that it does not just look at the cornea as a whole like all our air puff devices do. And this has been the only device which has been able to differentiate the strength between a cross-linked and a non-cross-linked cornea, and also differentiate between the anterior part of the cross-linked cornea versus the posterior part of the cross-linked cornea as compared to the controls. So we have a plethora of new investigations, and early diagnosis is extremely important, and which will help us to make timely and appropriate interventions. Thank you so much for the kind attention and the opportunity as well.